and for pharmaceuticals in my mind should be eliminated.
Yeah.
All this does, it doesn't improve the knowledge for the patient. It increases a conflict of interest that physicians are placed in every day. The patient wants this. Do I provide it? If I don't provide it, the patient's going to go to somebody else. So that conflict of interest has got to get out of the picture. Both procedures and pharmaceutics should not be direct ads to patients. Now, I realize that that's going to shut down a lot of television time. Maybe there's a win-win there. I think reasonable collection of scientifically valid data regarding provider, hospital, and insurer satisfaction is important. Right now, we have a bunch of marketing and opinion stuff floating around on the internet that's supposed to give you a recommendation about where you want to go place your life. I'm sorry, I just cannot understand why we need to rely on opinions that just happen to be into the internet. We have ways of collecting that data on an accurate basis and making the data available. There's good data finally available on hospitals and nursing homes nationwide. We need to continue that improvement. But it needs to be scientifically valid, and we need to protect it from the manipulations that can happen. I do believe that tort and medical medical liability reform are needed. When I've had the opportunity to work with Canadians and the Brits and the Australians in some of the VA trials that I work with internationally, I'm astounded at the difference between the cost of care in the VA system here and the cost of care in the Medicare and Medicaid system here as compared to other places around the world. And the biggest difference is the legal liability issues in defensive medicine. It creates tremendous waste. It creates tremendous pressure on the provider to do something that they don't really need. We can eliminate that. There may be a win-win there as well. Medical and health professions education. Those of us in this building need to be emphasizing prevention and enabling each of the professionals that we produce to function at the very highest level of their license. There are a lot of nurses and nurse practitioners who could function and do more if they were allowed to do that. And our system doesn't permit it. They're perfectly trained, they have a license, let them proceed. If we can move everybody to the highest point of their license, I think we have a good bit of the manpower that we need for the future. And that's not an easy position, folks. None of these are very easy solutions. I do think that one of the things that's being missed in the current discussion is that we need desperately a stronger and more integrated public health infrastructure to protect our food, our drugs, and our medical devices, and the consumer product safety. The FDA and the EPA, the Environmental Protection Agency, have been gutted. We need them desperately. If we do not put the infrastructural investment into public health, we'll pay for it later. Thank you very much.
Dr. Mike. I'd like to take some of your time. Many of you have heard motivational speaker Zig Ziglar make the statement that insanity is doing the same thing again and again, expecting a different result. Government-run healthcare delivery systems have failed to adequately treat sick patients in Canada, United Kingdom, France, the Soviet Union, and other nations. Currently, former Soviet bloc nations, many Scandinavian countries, France, and Germany have recognized these failures and are starting to change their policies to shift back toward private medical care delivery. Our government-run medical programs of Medicare and Medicaid are currently billions, if not trillions of dollars in deficit. Despite these facts, Congress has determined that a new government-run public health option will somehow fix all the problems that we've been talking about today. I have to be honest, I have my doubts. I think this congressional mindset meets the definition of insanity. I believe it would be logical, or more logical at least, to study what types of healthcare delivery and payment systems have worked well in other parts of the world, and just try and copy those and adopt the most successful elements of these systems to our system. I'll give you a brief example. Switzerland, for example, has no government-run healthcare. There's no employer-funded healthcare. Employer wages that would go to pay for health insurance flow directly to the employees. However, each individual must purchase commercial insurance. Each individual owns their insurance personally and must keep it in effect for a minimum time of 5 years before ever changing carriers. It does make you pay a little more attention to making your selection than some other consumer choices that you might make. This prolonged relationship between the owner of the policy and the insurer encourages the insurer to offer preventive services and long-term effective treatment for chronic disease to the policyholder. The insurance company is well aware that it will be responsible for that person's health and costs for a long time. It's therefore less motivated to cut financial corners in paying for care. The Swiss government does regulate minimum levels of insurance coverage and benefits. The Swiss are free to purchase whatever additional benefits above the minimum level of coverage they wish. Low-income Swiss who can't afford to purchase the commercial insurance are provided by the government from taxes with a direct subsidy with which they purchase the exact same commercial insurance that everybody else has. Coverage is universal and mandatory. Quality of care is quite high. Citizen satisfaction is quite high. The government makes no medical decisions. There are also no death panels, and runs no insurance programs. The Swiss pay 11% of their GDP into healthcare, and we pay 17.5%. Variations on this healthcare theme abound in several other nations. I invite you to do your own research. In the U.S., the American Medical Association has promoted healthcare reform for years. The essential principles the AMA supports are available on their website. And I'd like to just share a statement, and it's quite detailed, but I'll just give you a brief outline of the basic framework for reform that the AMA has been proposing for many years. And what the AMA says, and I'll just read it directly, we want all patients to have health insurance with subsidies in the form of tax credits or vouchers for those who can't afford it. We want patients to be in the driver's seat rather than government or employers. We want families and individuals to be able to choose from a variety of affordable health insurance options. We want those choices to be more affordable than they are now, and insurance market reforms are needed to make that happen. Patients must retain the ability to choose their own doctor and be permitted to enter into private contracting arrangements with their physicians. Medical decisions should be made by patients and their doctors using the best possible information. No one should be denied health insurance because of any pre-existing condition. Ideally, we want patients to own their own health insurance, even if it's financed through their employer. So if they leave that job, the insurance is not lost, just paid for differently. We want greater investment in prevention and wellness, so that preventable disease attributed to obesity and smoking are avoided, thereby lowering future costs. We want everyone to take responsibility for their own health, insurance protection for their family, and choosing a personal physician. We want everyone to make and carefully document their wishes about end-of-life care, even if you're now young and healthy. Through the AMA-convened Physician Consortium for Performance Improvement, the medical profession will continue and intensify efforts to develop evidence-based guidelines for quality improvement, providing physicians and patients with real-time data for decision-making at the point of care should the driving force for, that should be the driving force for quality improvement. We support efforts to improve care coordination and management of chronic disease, including the patient-centered home and greater support for primary care. It's starting to sound kind of repetitious, right? Current antitrust policy must be modified to enable small physician practices to pursue quality improvement, care coordination, and health information technology initiatives to achieve greater clinical integration in the delivery system, what Dr. Braden was just speaking of. Regarding cost, the AMA has pledged to do its part to help reduce the rate of growth in healthcare spending. The AMA convened agency that I mentioned above is developing